Today I'm going to do a short presentation which really sort of sets the scene for the day in terms of placing palliative care within a technology context. I'm assistant professor in Trinity College, but before I took that position I worked for a number of years in the health services myself. So I've had plenty of experience in terms of, I suppose, face-to-face contact in the field, working with people with palliative care needs, particularly in the area of motor neuron disease. So I'm going to speak a little bit about that today, and also to talk a little bit about the complexity of palliative care and situate that within a template of motor neuron disease. So when we think about a template for palliative care and technology, I suppose, what are we thinking? Often people think about technology more so when they think about rehabilitation services. And although rehabilitation does fall within the category of palliative care, it is only one part of it. But I think we can situate technology needs within palliative care in general. So when we think about palliative care or end-of-life care, we think about palliative from the point of diagnosis, from a care perspective. We often know that people, not everybody, but many people who have palliative care needs, particularly in the end-of-life care, lose their ability to move, so they lose their physical function, which can affect independence. They also can lose their ability to communicate, or their ability to communicate can be impaired. And I don't just mean about the practical sense in terms of people losing their ability to articulate or phonate, but more so also in the existential sense of losing their voice around the preferences for care. And also the obvious part, increasing care needs and increasing care burden with advancing illness in palliative care is something we face, that people with terminal illness or palliative care needs do face also. And I suppose from that perspective, the emphasis on technology, where is technology situated in this context when we think about people who are living with palliative care conditions? So yes, some of this talk relates to people who are living in end-of-life care, but people who have palliative care needs in general, and that refers to large groups of people who don't live with a terminal illness. So I'm going to use motor neuron disease briefly as a template here to show how a person with a palliative condition, or in this case a terminal condition, an MND, how technology can play an important role. For those who are maybe unfamiliar with MND, it's actually a much more common neurological condition than we think. It is a terminal condition, and therefore everybody with motor neuron disease, in terms of a care approach, receives a palliative approach from the point of diagnosis. It's quite a rapidly progressive condition. About 2/3 of people will actually pass away within 3 years of onset, not diagnosis, but actually point of onset. So it is actually quite rapid, and probably more rapid than other terminal conditions within the palliative care field. What's complex here is that people with motor neuron disease can develop cognitive impairment much more than we think, which also has an impact in terms of preferences and use of technology as people progress with their condition. But we know that cognitive impairment is not, MND is not alone in that, in terms of many other terminal conditions also involve cognitive impairment. But what is important about MND and how it's a good condition to use as a template for palliative care is that the care is interdisciplinary. So obviously palliative care is fundamentally interdisciplinary. It has to be symptomatic. MND care is symptomatic, is palliative, and also a large part of that care is provided during the end-of-life care stage. So it fits well from that point of view. So if we look at complexity of care, and I'm using MND as a template here, but think about any other conditions or any other people you have met that have had palliative care needs, regardless of their condition, it does translate. Because as healthcare professionals and as researchers, we look at not just the practical dimensions of illness, but we look at people in terms of different domains, so psychological, social, existential, as well as physical. And we see the person in the middle of that, usually with the people that are close to them, significant to others, and so forth. And things like we think about is loss, meaning, quality of life, burden, life course, progression, adaptation, and control, and coping. So there are key factors that a lot of research has been undertaken in relation to that are dimensions of these dimensions that we have to take into consideration. When we even think about whether people are going to use or not use technology. So To look at it a little bit even into more detail, into using MND as a template, care is complex. Okay, so even before we think about providing or assessing with technology or making technology more accessible for people to access within our health services, there's lots of things that are happening within that context. And we have to think about the different contexts which affect how people access, use, or can be assessed with technology. So if we see the person in the middle engaging with services, but we know that it's quite much more complex than that, because there are many things outside of the service user and their significant others or others that are shaping things, shaping how the patient or the service user engaging with services for their technology needs. And this is a nice template in terms of motor neurone disease, but we can use it for other conditions. We could think of, not only the micro stuff that's going on at an individual level for the person, but also things that are happening at the outer rings, which is your meso level and your macro level. So we're taking into consideration, in terms of our healthcare services, our secondary care services, our primary care services, which are shaped by our tertiary care, which are shaped by actually evidence-based practice from an international perspective. So everything we do in terms of even technology is shaped by this. This is a nice, I think, picture or diagram of interdisciplinary care for people with motor neurone disease, but again, it can represent many other conditions, many other people who have palliative care needs, because the approach is palliative from the point of diagnosis. So we're full familiar that palliative care is interdisciplinary, and this is really just a good, I think, example of the variety of healthcare professionals that are involved in the care for people with a condition like motor neurone disease. And you'll see there that I've highlighted in yellow non-HCPs, engineers, architects, IT. And these are people we would normally associate with actually the technology needs of people with, for instance, this with motor neurone disease. But actually, technology is used, assessed, and intervened with by most people of the multidisciplinary team, particularly in the context of motor neurone disease. Just some examples of technology use in motor neurone disease. Environmental control systems, computer brain interface systems, complex augmentative communication systems for people who lose their ability or their ability to communicate is impaired. The assessment, we often forget about the technology that's required in terms of the clinical assessment for motor neurone disease or different conditions. That's also technology. Voice banking is a technology for people who have lose their ability to communicate. Sensory technology is definitely a developing area of motor neurone disease, and I know we have a researcher here from Trinity College, Dr. Deirdre Murray, who I see over there, who has a poster here today and is actually undertaking some HRB-funded research on developing sensory technology for actually assessing the advancement of MND and trying to develop some novel solutions to doing that as opposed to the traditional outcome measures we typically use. And Deirdre has a poster here today, and I'm sure we'll be happy to talk about that. Two more future care. We've mentioned that we will have a talk today about the use of robotics in dementia, but also in terms of just care needs. That is where the future may well lie. And I suppose coming down to the more low-tech technologies around assistive devices to compensate for the loss of function, the loss of one's independence. Often this type of technology is much more readily available because it's cheaper than high technology, but it's also technology. We often don't think about low technology as, as technology in terms of novel solutions, but they're very novel because people use them on a daily basis. So all of this is technology, okay? So often we get excited about very novel developments in the area of developing new technologies, which is quite important. But from a practical point of view, in terms of everyday activities of people with palliative care needs, such as motor neurone disease, often those very more baseline, more basic technologies can prove most effective because they're actually more readily available and financially accessible to people. So even after we think about the individual circumstances for a person like MND and their significant others, we have to think and what's going on in their own lives, which can shape how they choose to engage with healthcare, with technology and healthcare services, there are also other factors that really facilitate, but also can impede how people use technology. And these are things that we need to be aware of because they shape research and they shape services that can be provided. And that really is the challenge in people accessing technology specialists. They're not readily available within our public healthcare services. They're not even really readily available in private healthcare services. So how do people access treatment and assessment with technology? Okay, we all know that technology is very, very useful, can improve people's quality of life and palliative care, but people often in our healthcare services, public or private, have a big problem accessing baseline technology because of the cost. And the question around funding for technology and assistive devices, is it public, is it private? It's difficult to acquire in either sector in our sort of hybrid system here in the Republic of Ireland. And in the case of motor neuron disease, actually, the voluntary sector in the Irish motor neuron disease really provide a huge amount of assistance in covering the costs of that. So in terms of motor neuron disease here in the Republic of Ireland, a significant proportion of people's assistive technology needs are actually covered by the voluntary sector, which is mainly voluntary contributions from the public. And industry, the potential role for not just in motor neuron disease, but in terms of palliative care in general, the role of industry to financially contribute to the availability of technology is something perhaps people don't talk about so much, and perhaps is there a responsibility on public or private industry to not only to develop technologies, but actually to make sure that they're more available in terms of much more financially accessible. And that's a key thing, I think, in terms of making technology more accessible than we have it. So they're the macro facilitators and barriers in care context that shape the bigger picture. And I just want to, before I finish, come back to the micro context, because you'll see here I talk about to using or not using technology. Obviously we're here today because we all realize the role and the potential for the role of technology in improving people's quality of life and palliative care. But it doesn't mean that everybody uses technology or wants to use technology. It's not as simple as that, particularly for people who live with conditions that are advancing and that are progressive in nature, because there are complex adaptive processes happening regardless of all the macro stuff that I just spoke about. And I think we need to be much more attuned to when we're designing technology at the very, very beginning in terms of the concept phase and getting service users' views around what their needs are. Things we probably need to be more attuned to as researchers and as clinicians is choice. What do people actually want? Okay. Autonomy, very, very important as people advance, particularly in the latter stages of their lives in palliative care. Cognition, this is complex because we know that in some cases, as people progress in the advanced stages of their condition, that their cognitive ability can be impacted. This does not mean that they don't know what their preferences are, or their preferences aren't as weighted as previously before, but it does make the picture a little bit more complex in terms of choosing different types of technology that are safe or not. And that relates to decision making, to use or to not to use, okay? And coping. People cope in different ways. And certainly a huge amount of research in the area of motor neuron disease has looked at this. And it's not as if everybody copes in the same way. They don't. There's lots of different types of coping patterns. And often people have different rates of acceptance in terms of their condition, which can also shape whether people use or don't use technology. I worked, as I said previously, many years with people who have neurodegenerative diseases, where the nature of the condition means that they progress. And often using technology for them was a sign of disability and disablement at certain points along their disease trajectory. So it's not the case that everybody who is living with a condition and who is receiving palliative care services, and particularly people who are living with a terminal condition, will invariably immediately want to use technology. It's a little bit more complex than that. And that relates very much to people's perceived performance around independence and dependence and how they're coping or not with their progressive needs, and how it impacts on every day. So people's perceptions of enablement can be very, very different. And often there is a distinct difference between healthcare professionals' viewpoint and researchers' viewpoint on that, and also the viewpoint of the person who's actually living and who has palliative care needs. And very important is family carers, who we know are key support structures for people who have palliative care needs. And they're central as well to the decision-making process in all care needs, not just in technology. And often technology preferences and how we use technology in the assessment and the intervention are very much what we know, on the face of it, shaped very much by family carers' needs and their preferences for care. So thank you very much. I hope I was under 15 minutes. Okay, thank you.